All right, welcome. So over the next few minutes, we are going to talk about looking at a differential approach to chest pain. I'm broadcasting from my office today. So again, my name is Basil AC. If you have any questions or comments relating to this broadcast, please don't hesitate to send me an email. My email address is basay@vcu.edu. Just as some housekeeping items, I apologize on the forefront if you hear helicopters flying around and sirens downstairs. I'm in my office, and sometimes it is and can be very loud here. All right, so let's take a look at the presentation here today. I'm going to be, again, talking about chest pain and a differential approach to how we both assess it and manage it as well. Okay, some of those early treatment options here. So bear with me. So again, here's, all right, so chest discomfort. 12% of all emergency department visits come in with complaints of some kind of chest pain. Costs the hospitals annually millions and millions of dollars because just an unbelievable amount of hospitalizations occur as a result of these emergency department visits. Of complaints of chest pain, about a third of them are even found to be of cardiac nature. So just so that you know, a lot of people very often are released from the emergency department who did end up having an MI, but it went unrecognized, an MI meaning a heart attack or otherwise. So they end up being released from the hospital without even having had the diagnosis of having had a heart attack. So this is something that very concerning. Differentials. When we're looking at chest pain, when someone comes into chest pain, think about all the different things that it could be. Okay, think about all the different things that chest pain could relate to. It could be musculoskeletal in nature, such as somebody who lifted something the day prior and it caused a really bad strain. It could be gastrointestinal, as in heartburn or gallstones, or it could even be in esophageal spasms. People who have had long standing GERD or heartburn for a good part of their life can have a lot of pain associated with having an esophageal spasm, when that sphincter at the bottom of the esophagus actually gets eroded to the point where their esophagus starts to spasm out, and it causes a considerable amount of pain. So that's one possibility. Other things could be chest pain, just non-specific. 16% of people who come in have some kind of non-specific chest pain. Angina, okay, or you might hear it called angina. That is cardiac pain. Okay, it could be related. It could be an MI. It could be stable angina, something that a patient has known for a while about, or it could be unstable angina. All of those are possibilities. Psychosocial, okay, so somebody who has anxiety, they would, and very often do, describe their pain as being chest pain. Pulmonary causes, okay, so obviously the big ones, pneumothorax or a PE, those are very concerning, of course, and could cause chest pain, but also the things like infection and such, like pneumonia or tuberculosis. There are other causes of chest pain in that whole area as well. Herpes zoster virus. Will anybody remember what that's called when it presents? It follows the nerve tract. If you said shingles, you would be absolutely correct. There are also other causes of chest pain, such as pericarditis and such. The initial approach to managing anybody who comes in with a complaint of chest pain is basically assume the worst with this patient. We're going to assume that something bad is happening until proven otherwise. So this patient's going to get the same treatment regardless. They're going to get 100% oxygen. They are going to receive IV access and be hooked up to a monitor. We're going to get that 12 lead as soon as possible, preferably in less than 10 minutes. We want to be able to capture what's going on. We also, if available and if not contraindicated, we'll start some pharmacology treatment, such as what we have heard for a long time referred to as MONA, aspirin, nitrates, oxygen, okay, and morphine. So you would also probably start that. And all this is going to be done at the same time while we are getting a history from our patient. Very important. Anytime that we have a patient who's complaining of chest pain, that we find out, well, when did this start, and kind of just some backstory history. Because remember, any pain, chest pain included, is very subjective in nature. So the only way that we can truly assess a subjective complaint is to obtain a good and thorough history. So again, our chest pain assessment involves a history. We're going to want to definitely do a physical examination, obtain a 12 lead. We're going to put them on a monitor. We're going to expect that the doctor is going to order some cardiac enzymes. So we're going to be drawing some blood. Okay. We're going to expect that there will be some chest x-ray, and there might be some other things that the doctor wants specific to this patient population. So all of this really needs to be done within that first 5 to 10 minutes, okay? Preferably, I like that 5-minute window, okay? Because remember, time is muscle. When we are taking an approach to treating pain and to assessing pain, we need to do it systematically, okay? And so one of the first things we look at is what kind of characteristics does the patient present with as far as the pain? How do they describe it? Is it visceral? Is it somatic? Is it neuropathic? Okay. Is it, if it's visceral, that means it's that dull, deep, throbbing type pain. That's usually associated with pain of, a nature that is involving some kind of organ system. Okay. Whereas somatic, it's more that sharp pain that has to do with, something that can be reproducible, could be musculoskeletal or something like that. Neuropathic, there are special populations that experience more neuropathic pain than others. The population that I'm thinking of right now definitely would be an oncology population. They often complain of neuropathic pain, but not so much in the area of the chest. However, a person with shingles certainly could have pain of a neuropathic origin. So we want to ask them, how would they describe it? And we don't want to give them any, leading answers here, but we would hope that they, ask them, in the sense of how does it feel? Can you describe what it feels like? If it's a sharp pain, we could think, possibilities of, pericarditis or that neuropathic pain. If it's a squeezing, a pressure, okay, we worry that if it's that dullness, remember, if it's like a visceral pain, then we're worried about internal organs, or in this case, the heart, okay, more specifically an possible MI or angina. Is it stabbing? Okay, some people might say it's stabbing. In that sense, if somebody tells me it's stabbing, I'm going to start worrying about, inflammation of some kind. Maybe it could be, that could even be pericarditis, or even like a gallstone attack or something like that. So if it's pleuritic in nature, pleuritic meaning in the lungs, okay, when it hurts to breathe, okay, so the pain is reproducible when they breathe in, okay, and then we're going to think, well, is this possibly a PE, or is it an infection, a pneumonia, or something like that? If they describe it as that classic tearing sensation, then we're going to be really concerned, okay? We're going to start thinking the aortic dissection, because there's very few times when somebody's going to say they feel like they're being torn in half, or something is like tearing in their chest. Other people, especially in the population experiencing an aortic dissection, they may describe their feeling as a stabbing or something radiating directly through to the back. We're going to talk about radiation here in a minute. If it's burning, okay, could potentially be heartburn or GERD. We could also ask if it's associated with meals, or if they're, at a time when they are eating or something like that. So, all right. So the other thing is we want them to more specifically tell us where the pain is. To just say it's in the chest may be too broad. Okay, so we want to ask them: is this, in the lung area? Is it right over the heart? Can you feel it? Does it go? Can you feel it in the back? Is there any pain? Those kind of questions. So ask that in conjunction with radiation. Does it go anywhere? Is it moving? Okay. Does it come and go? That kind of thing. All right. So, we would expect, sometimes if it's radiating up towards the neck, okay, and it originates in the central sternal area and radiates directly up towards the neck, is that an esophageal spasm? Possibly, maybe. Okay. Also, what about if it's, like I said, kind of just stabbing right through? They not only feel tearing, but they feel a radiation of the pain stabbing right through to the back. Okay, what are we concerned of then? I mean, again, we come back to these life-threatening, what's going to kill my patient in the next 5 minutes, an aortic dissection. Okay, so we are narrowing things down through our clinical approach to assessing chest pain. Okay, again, we know that classic sign, or I guess here symptom of an MI or chest, or I apologize, of cardiac pain, where it radiates up to the neck, to the left, to the jaw, okay, down the left arm, that kind of stuff. So we start thinking, well, if this whole constellation of complaints here and we have radiation, is this possibly an MI? All right. We want to also know about their onset. Onset could be very important. Did this come on suddenly, or did it, occur gradually over time? Okay, if it was sudden, even that, I would still want to know how long they've been feeling it. So it came on suddenly, and it's of an acute nature. Okay, possibly could it be a spontaneous pneumo? Could it be an MI? Okay, how long has this pain lapsed over? Is it, if in the case of some people who have angina, is this any different than the times in the past when you felt it? If it's gradual, you can think, well, could it be of an infection process? Okay. Could it be GI related? All those type of things. All right. So also, we want to know, again, back to timing. Is this something that, how long? Okay, how long here? Because if it's less than, 15 minutes, or roughly 2 to 10 minutes, and it's a pain that they've felt in the past, then we can probably say that this is stable angina. However, if it's new, if they've never felt this pain before, and or it's changed in some way that's concerning them, and it's lasting greater than 30 minutes, we definitely want to be concerned that this could potentially be an MI, okay, or unstable angina. If it's lasting up to if it's lasting up to 60 minutes, okay, it could be something GI related or an esophageal spasm, few hours to days, okay, pericarditis or another infection, okay. If it lasts longer, think about shingles. People who suffer from shingles have that over quite a long period of time. So asking about duration is very important. Note here that if pain only lasts, less than 2 to 3 minutes, it's really unlikely that it's cardiac in origin or related, but you never know. We also, sorry about that, I keep going backwards. All right, so what makes it better or worse? Ask your patient, are there any provoking factors here? When you get out and work, okay, does exercise make it hurt worse? Does cold or being under a lot of stress in some way make it worse? Okay, if that's the case, we might want to consider possible ischemia. How about swallowing, or is it associated with meals or smoking? Remember, smoking is a trigger for acid reflux sometimes. People don't realize that. Other things is, does taking a deep breath aggravate it or make it worse? Okay, what makes it better? If you stay still, does it seem to get a little better? Ask these type of questions. Again, ask about if it hurts worse or less if they take a deep breath. Okay, usually shingles are not, herpes zoster is not aggravated by anything. So it's pain of a neuropathic origin. It's just there. It's there is there. So as far as relieving factors, okay, we want to ask them, does anything make it better? All right. If they take an antacid, is it better? If I give them nitro, or if they take their nitro, if it's already prescribed, does that make it better? All right. Just remember, when we're talking about severity, it doesn't indicate that it is more severe or more serious than something else. Okay. So severity doesn't indicate seriousness. All right. Let's see. So any other associated symptoms here, those kind of things we want to find out and ask about. Do they have any nausea or vomiting? Are they, spitting up blood or hemoptysis? Is there any, dyspepsia or indigestion? Do they feel palpitations? Do they feel like their heart's racing? Ask those, those kind of questions. Have they had a cough for the last few days? Do they have a fever? Have they had something going on as far as that might indicate that this is a potential infection? What is their psych history? Okay, do they suffer from anxiety, depression, or having had panic attacks in the past? Okay, and have they ever felt like this before? All right, so then we move to our physical examination. When we're thinking about, obviously at this point, we're going to start getting some vital signs, looking at remembering hypotension can occur in MI. Hypertension can also occur, but we want to be extra vigilant in noting when hypotension is there, because sometimes hypotension can also be an indicator of a right-sided MI, which we will talk about in a minute here. But also pericardial tamponade. Okay, it'll happen there. You see hypotension also in a PE or also a GI bleed. So any one of those things that could potentially result in shock, we could see blood pressure changes. Remember, when we're taking our vital signs, if we have a fever, it could potentially suggest an infectious process or other type of disease. In the case of pneumonia or sepsis or something like that, we want to actually look at the chest, inspect it, okay? If you see a rash, you may think shingles. If you put your hands on it and you feel crepitus, okay? Or a floating segment, therefore they must have had some kind of trauma, right? Therefore, you want to find out also if pain can be localized to a very specific region. Are they extra sensitive in one area versus another area of their chest? All right. Also, when we're listening, auscultating our cardiac sounds, remember, listen for those extra heart sounds. Listen for that S4, okay, or that extra gallop, okay? Some of those type of things might be indicative that this patient is suffering from congestive heart failure, okay? Also, we can look at their jugular venous distension, JVD. Beck's triad usually is indicative of some kind of cardiac tamponade. Beck's triad is a very late sign. If we're starting to see this, we're really concerned that this patient is already very far progressed down the track of we may not get this patient back. So we want to, of course, be able to assess and come to some kind of a determination and treatment plan far before they get down to the road of Beck's triad. But that includes the JVD, muffled heart sounds, and low blood pressure. All right, so another assessment piece you can do is when doing the vital signs, you want to make sure that you do blood pressures in both limbs, or make sure that you check for pulses in both radial pulses. assessing quality, okay? Because especially in the sense where you have an aortic type dissection or an aortic aneurysm, yeah, up in the arch, you may even find out that they have some variation or differentiation between the two limbs. All right. Also, listen to breath sounds. Okay, are they equal? Do you hear any adventitious sounds like wheezing or crackles or anything like that? And we did talk about hooking them up to a cardiac monitor, getting that done quickly. I also anticipate getting IV access early on, because we're going to know that we need to draw our troponins. Troponins are the first enzymes to rise, and they usually remain elevated for a few days. Okay, so most often doctors will order serial enzymes, troponin levels every 6 hours, very often. Another thing that we want to look for is an echocardiogram. Okay, and if we do get an echocardiogram on our patient, they may have, that could be indicative of some type of valvular disease. They could see the perfusion through the heart, okay? It may also indicate at times pH or pulmonary hypertension. Also, we want to expect that this patient's going to get a chest x-ray. They could also have a pneumothorax or pneumonia. And when we're thinking about ruling out some kind of other process like a pulmonary effusion or a PE, we might expect that a doctor could also order a D-dimer, and D-dimer would be elevated in those cases. Let's see. Other tests that we could also run is looking at their chemistries. We're going to look at their BUN. BUN would be elevated. It's a blood urea nitrogen. That would be elevated in a patient with what? With a congestive heart failure. I apologize. I said that wrong. It was actually a BNP would be elevated in somebody with a increased volume, intravascular volume, and that would be a BNP. Your BUN and your creatinine are both markers for kidney function. Other things that you might want to check is, do a skin test such as tuberculosis. If, tuberculosis could also cause chest pain. If they have a long-standing history of having GERD, we want to check their esophagus. They might even go in for other kind of diagnostic evaluation like an EGD, where the doctor puts a tube down their throat and they kind of look at, if there's a lot of wear and tear on their esophagus. Or some patients may not warrant any type of other diagnostic testing. So, sorry, one more thing. So let's do a case study here, and I'll come check on you in just a minute. All right, so let's do a case study real quick. The case study is, here we have a 48-year-old female who walks up to the desk and says, "My chest hurts." All right, pretty common. All right, you notice very quickly that there's no increased work of breathing in this patient. Her blood pressure is 142/80. Pulses are 110. Respirations are non-labored at 18. Oxygen saturation is at 94% on room air, and she, from her history, is about 55 kilos. All right, no past medical history except for 2 vaginal deliveries long ago in the past. She's been taking Tylenol, she says, for discomfort, along with over-the-counter cold medications. All right, and she says she's had a bad cold with a cough for about 5 days. So right off, do you know any life-threatening signs or symptoms here? Anything that's really concerning to you? Not really. Okay, so we need more information. The patient is placed into a wheelchair. You take her to your monitored room. All right, she's alert, oriented. She's able to converse with you. She's cooperative. Okay, she has chest pain. She maintains her own airway. No unusual noises. You listen, you auscultate her lungs. They're non-labored. Her lungs are clear. All right, her skin is warm and dry. Pulses are palpable. What would you expect the doctor to order at this time? what treatments are appropriate. All right. I would at least hope that you would immediately say, we need to get some vital signs on this patient. I need to get a history on her, right? When you'd want to ask her some more questions, I'm assuming, because this is chest pain, we need more information. So she tells you this has been increasing over the last few days. It's a dull ache. It kind of originates right there in the middle of her chest. Lying down seems to make it worse. It doesn't seem to go anywhere. There's no radiation. And she rates it about a 4 on a numeric scale. All right? It's a steady ache. But if she lays down or if she's supine, the pressure seems to increase a little. All right? Would you like to conduct any further assessment here? Anything else you want to know? I know for sure I would. So let's find out some more history on her. What's going on? She says there's a dull ache with dyspnea at night. No known allergies. Okay, she doesn't have much history there. She's been taking acetaminophen as needed, Tylenol. She's taken Claritin for the last 5 days for a head cold. All right, but otherwise she really doesn't have any significant history. She ate a small amount 3 hours ago, but doesn't really have any appetite. And you're wondering, is this musculoskeletal? So you ask. She denies any trauma. She says she hasn't lifted anything or anything like that that could have caused muscle strain. So what's your initial impression? If you were to cast out that great big wide net of all possible diagnoses, what do you think this could potentially be? Why don't you grab a piece of paper and write that down? Just talk it out in your head. What kind of things do you think could potentially be at work here? All right, and then we're going to move on to so after you kind of get a few things in your mind, okay, we need more information. All right, our initial management here is oxygen is applied at 2 liters, nasal cannula, IV is established and blood is drawn for analysis, and the monitor shows sinus tach on lead 2 at a rate of about 100. So you look down there at your lead 2. Anything concerning to you? Do you see anything? Her pulse oximetry is at 99%. You got her on 2 liters. Good job. All right. I don't really see anything. Looks fairly benign on lead 2. All right. So what do we need? What do we need from this patient? What should we have done already? If you said 12 lead, you're absolutely right. Let's get that 12 lead. So let's look at our 12 lead here. This little discussion we're having here is not intended to teach you everything you need to know about 12 lead. That's for another class. However, I do want to point out here that you do see some interesting ST segment elevations, right? You see a little bit of an elevation in 1. I see a little elevation in 4. How about 5? Okay. 2 here does show a little bit of ST segment elevation. All right, so you see, oh, 6. I see 6 as well. And can you give me a 3? Yeah. So anyway, regardless, you have some pretty diffuse ST segment elevation. It's non-specific here, okay? So what do we need in order to diagnose ST segment elevation MI or a STEMI? We need 2, okay, count on 2 continuous leads, ST segment elevation, okay? And it'd be helpful if we could have some reciprocal changes. All right, so that component of interpretation is for another class, but this one does show some diffuse and abnormal ST segment elevations, which to me would be concerning for potential pericarditis. With that said, does her other assessment criteria fit that clinical picture? Absolutely. So what should we do with this patient once we assessed and found that she potentially had pericarditis? What other things did we see in this patient that made us concerned in that way? We saw that it gradually came on, okay? She didn't necessarily, if I remember right, she didn't have a fever or any other thing that was concerning for an infection, but she certainly did have other complaints. She said that it was worse when she laid down and such. So with this patient, let's go back to our, with this patient, we would expect that they are going to probably be, let's see here. They're going to probably be treated on, I apologize. They're going to be treated with some steroids, all right? And potentially also have some ibuprofen administered if it's not contraindicated. This specific patient was dismissed 3 days later with a tapering dose of steroids, and basically she was continued on ibuprofen. So let's see here. So if we come back, that's basically our discussion about chest pain. If you have any other questions, please don't hesitate to send me an email. Look forward to hearing from you, and I appreciate your time. Thank you.